welcome to everybody and ask them to turn off their video?
I can do that from the podium.
Okay.
So will there be people up there who want to be seen?
No.
No.
It's me. If you just see the picture.
Jeanette,
Hi.
I can hear you.
Hi, Josie.
How are you? I think most women or the audience can hear you too. You may want to mute yourself, Chris.
Hey, everyone. I'm Denise Wickline from Magee-Womens Research Institute and Foundation. I know I've spoken with you and talked to a lot of you, so I thought I'd put a face with a name. We just have some logistics that I wanted to share with you before we bring Dr. Van Lunden up. If you notice that everyone's been muted, so please stay muted during the entire session. And also if you can turn your videos off. And if you're calling from a phone, if you could just please silent your phone. The other thing is that if you have a question during a presentation, if you look at the top of the screen, you'll see a couple icons at the top. You'll see one that shows like two little people, and then right next to it is sort of like a comment symbol. If you click on that during the presentation, just like that, you'll see at the bottom it says type a message. That's where you should be typing your questions. We have Colleen Straub here from our foundation. She's going to be taking the questions and sharing them during presentations. Presentations are 30 minutes. 20 minutes will be allotted for the presentation and 10 minutes for Q&A. So we'll try and get as many questions as we can. So with that being said, I'm going to turn it over to Dr. Van Lunden, who's going to do a welcome.
Thank you, Denise. Can you hear me, Denise?
I can hear you.
Good. It's weird to be speaking to a screen, but just bear with us. This is the first time we do this virtually, but we'll, hopefully we don't have too many glitches to work through. I'd like to thank all of you for coming to our 14th annual Magee's Livewell Survivorship Workshop. We hope you're able to visit with the exhibitors today, right between 4 and 5 p.m. and received some valuable information. The design of this workshop today is to be an interactive session with experts in the field of women's health, cancer, and survivorship. Magee's goal is to give patients as much information and tools to assist them during and after treatment. Today would not have been possible without the hard work from our planning committee. I'd like to thank Troy Trainer, Linda Ankrum, Cindy Schaefer, Barb Sukonik, Gina Angel, and Sarah Maloney for all that they've done to organize today's workshop. We also would like to thank Denise Wickline from Magee-Womens Research Institute and Foundation for organizing all the logistics for today, as well as the sponsorships, so that we can continue to offer these workshops to you at no cost. Furthermore, we'd like to recognize the sponsors for today's workshop who stuck with us as we went from a live event to a virtual one. Your commitment to the education of our survivors is greatly appreciated, and I hope you got to meet some of them during our hour-long exhibitor session prior to this workshop. The corporate and organizational sponsors are listed in your program and were shared with you at the beginning of this workshop. However, in particular, we would like to acknowledge the presenting sponsors for today, UPMC Health Plan and Novartis. Many grateful patients lend their support to educational programs at Magee by donating to our research and educational funds, stewarded by the Magee-Womens Research Institute and Foundation. For example, as I can speak for my particular program clinic, we had a private donor come forward and they allowed us to offer free personal trainer sessions with our cancer survivors, which is greatly appreciated. As we all know, there's that small window of time, and often a little push is needed to allow people to sustain that momentum. The need for funds to continue our research is even more vital. I'd like to introduce Janice Devine, Executive Director of the Magee-Womens Research Institute and Foundation, who will share the future of women's health and how you can help. Hopefully, yes, there. Thank you.
Thank you, Dr. Van Lunden. Hi, everybody. I hope you can see me and hear me. Can you see me and hear me? Great. I'm thrilled to be with you here all today, and I'm just really happy to be part of this workshop with all of you. So this is my first year participating in this event, but today marks our 14th anniversary for sharing this important information to you to help you through your survivorship journey. It's not an easy journey, emotionally, physically, and even spiritually. But as a survivor or a caregiver, cancer has taken time away from your jobs, your families, and changed your life in profound ways. But you are here with us today. And by being here with us today, it shows that your dedication in staying educated on the latest information, which will help to keep you safe and healthy. So at UPMC Magee-Womens Hospital, our physicians are dedicated to their patients. Also at Magee-Womens Research Institute, our researchers are dedicated to also discovering new ways to detect, prevent, and hopefully cure cancer one day soon. Our research is creating new, more effective and personalized treatments for breast and gynecological cancers. But this dedication, as you know, is very costly. More than ever, we need your help. With government funding being cut for women's health, it's very important that our foundation raises even more dollars for patient care and research. So if you look at the back of your program, you'll see that we've shared a couple of ways that you can help to support us. All gifts, no matter what their size, will really help us and will help to make an impact. Whether it's for patient care or research, your support will help us to advance clinically and continue vital research. If you have any questions at all and you'd like to discuss how you can make an impact or how you can support us, please look at the numbers. You can call or email that number, and either I or someone on my team would be more than happy to talk to you and share different ways and just share information about how you can make an impact to help us. Again, I'm just really thrilled to be here with you today. We have a great lineup of topics, and we offer our heartfelt thanks to you for trusting us with your future. So then now it's time to get this workshop started. So each presenter will speak for about 20 minutes, and then we're going to have a 10-minute Q&A session. At the top of your screen, you'll see a comment icon. Click on that, and at the bottom, you'll see where you can type your question. I know Denise already shared that with you. I just want to tell you again, look for the icon at the top, and then you can type your questions at the bottom. We'll get to as many questions as we can during that 10-minute period. But due to the nature of this program, our speakers will be unable to provide individual clinical advice. So we encourage you to talk with your physician or call Magee for an appointment. So our first speaker will be Dr. G. Van Lunden. Dr. Van Lunden is an associate professor at the University of Pittsburgh, an ABIM certified medical oncologist and a geriatrician, and as Denise mentioned earlier, is the director of the UPMC Cancer Livewell Survivorship Program. Let's welcome Dr. Van Lunden back for her presentation.
Thank you, Janice. Chris, can you see my slides?
Yeah.
Yes.
Good. Okay, so I think you can hear me, maybe see me in a miniature version, but my slides are up, which is the most important thing. Most of you know me as Dr. Josie, and I was asked today to talk about something along emotional lines, and I thought maybe I should talk about the pressure we all feel as a cancer survivor to make every day count. And I'm going to make a little twist to that story by talking about green eggs and him. I will leave you in suspense until the second part of my lecture. I have no relevant financial conflicts of interest. Oh, wait a minute, hold on. Next slide, I think. There we go. So the take-home message, hopefully at the end of my 20-minute lecture, will be that I hope you will feel empowered to put taking control in perspective, to feel more comfortable, to speak your needs and your wants wherever you're at, to hopefully improve your quality of life and therefore also your health outcomes, and to give yourself permission to just be, play, and roam. And that I will leave for the second part of the lecture. Next slide. As you all know, there is a balancing act between your medical issues and your non-medical issues part of your life as a cancer survivor, and that balance is very hard to achieve. And when you have it one day, you may not have it the next day, even maybe not even the next hour. And so it's a never-ending balancing game that hopefully after today you will feel a little better balancing it yourself. There are 5 main parts of cancer survivorship care in terms of the medical aspect of cancer survivorship, and that includes surveillance, watching for a recurrence of the cancer you have been diagnosed with, as well as screening for new cancers, as well as assessing and managing the post-treatment symptoms, late or long term, that you may or hopefully won't develop, health behaviors or lifestyle, as well as coordination of your care, which can be sometimes a little overwhelming. These 5 main parts of cancer survivorship care have been decided upon by institutions that are listed in the bottom of this slide: the Institute of Medicine, the Livestrong Foundation, the American College of Surgeons, and many more. And you might think this is common sense. Why are we not doing this routinely? And that is indeed a very good question. We don't really have the answer for that, but there was a need to declare these the essential parts of survivorship to allow everybody in the United States to have access to all these elements of care. And I will go through them one by one. Cancer surveillance includes the monitoring for the recurrence of the cancer you've been diagnosed before. This includes office visits that may lessen over time, as well as a personalized schedule of testing that may or may not include imaging or laboratory testing, and that may differ from one person to the other. And so it often raises a lot of questions as to why your personalized schedule is different from somebody who seemingly even has the same tumor type. And my take on that is that most commonly you're being told what to do for you, which is most likely appropriate, but it does not hurt at all. Don't be embarrassed or ashamed to ask the next time you see the doctor, hey, why don't I get a scan, or why don't I get blood work? In particular, for breast cancer survivors, we have a very strong foundation of evidence to say that for the average breast cancer survivor, there is very little yield of doing routine imaging and routine blood work, and the big bulk of surveillance follow-up includes regular office visits, you coming in and telling us what's happening with you, as well as us examining you. That leads next to the question, okay, now I have this huge burden on me in terms of being able to tell my doctor when something is bothering, because we don't routinely look for things anymore, objectively speaking, with blood work. or scans. And so I usually explain to my patients, if you develop a non-acute symptom that is either totally new for you or you've had it for a long time before, but it's changed and it stays like that, then feel free and comfortable to call a provider, ideally your cancer doctor or somebody in your cancer doctor's office who might feel more comfortable advising you on whether or not this could be related to cancer. And then you may get 3 possible answers that sit on opposite ends of the spectrum. They may tell you, well, this does not sound related to your cancer at all, so maybe ask your PCP to help you with this particular problem. On the other end of the spectrum, they may say, well, sounds a little bit like we should do some further workup. Why don't we do some scans? Why don't we do some blood work? Have you come back into the office and talk about the results and how your symptoms have evolved? And hopefully at that point, testing will be negative. What I mostly encounter are those in the middle of the spectrum scenarios where the symptoms are probably not related to cancer, but the presentation is not specific enough for us to be able to diagnose it. And in that case, I tend to say, why don't we just watch it for a few weeks, maybe a month, either talk by phone or have you come back into the office and then see how things have evolved. If things have resolved at that point, it most likely was not related to cancer if there was not a specific cancer treatment started in the meantime. And so this will help you understand that you're part of a team where you work together with your provider. You know what's happening with your body, but you may not know how to make sense of it. And then hopefully you will feel comfortable enough to call your cancer provider to ask them to help make sense of it. So you don't have to Google overnight. Okay. Screening for new cancers. I'm going to keep this slide relatively superficial because I think you've heard about a genetic speaker last year, if I'm not mistaken, and this topic is very lengthy. But in general, once you've had one cancer diagnosis, you're at a slightly higher risk for developing another cancer in your lifetime. And many of my patients ask me, what does this mean and what can I do about that? And a mentor I worked with in the past explained it very nicely to our patients in terms of there's 2 levels of risk above the population risk. And the highest level of risk represents those individuals who have a so-called gene mutation such as BRCA or BRCA1 or 2. And if you would carry such a mutation, then it is pretty well defined, almost like a cookbook recipe in terms of what we should do for you when. But if you don't have a gene mutation, then your risk falls anywhere in between those with a gene mutation versus the general population, and we can't further specify that. And most importantly, we then don't really know what to tell you other than continue to be compliant with the age and gender appropriate national guidelines, with which a primary care physician can help very well. Many of my survivors have not seen their primary care doctor for a long time because they're so overwhelmed with their cancer care. And so that's one little hint that it might be important for you to touch base with your primary care doctor, because that person may not even know perhaps that you went through all your cancer journey. But again, individual circumstances may warrant personalization. The post-treatment needs, this list is by no means complete. And many individuals, as you may have experienced, may have many symptoms happening at the same time. And I've titled the slide with the word needs because not all of these symptoms may give you symptoms, such as, for example, heart health. If certain treatments predispose you to the development of heart disease down the road, then you may not notice that until you get a cardiac event. And the same with bone health. If your bone health continues to lower in terms of the bone mass, then your risk for fracture may go up, which you may not feel until you break a bone. And so not all of these post-treatment issues are symptoms, but also needs. And that is where health maintenance is very important, to try to titrate those risk factors and slow down the decline, if you may. Some of these symptoms are only short-term. Some of these symptoms or needs may stay with you for a while, if not for a really long time. Some symptoms don't start until later. Some may start right from the get-go. Many of these symptoms can be clustered, and it's my opinion, if that is the word to use, that shared decision-making is very important, that the patient and the provider together decide and choose from a set of options what might be best for them. Often for these symptoms, there's not a best first-line treatment approach that might be better than another. And so given that several treatment options might be possible to provide relief, it might be best to find one that the patient buys into and feels comfortable doing. And with that, I mean, for example, certain treatment options include a medication, and certain treatment options may include non-pill treatment options, which might be harder to do and perhaps more expensive, but avoid you needing to take more toxic materials in your body that I know many of you are not very eager to do so. Now we're moving on to lifestyle. Lifestyle determines part of your outcome, besides obviously the treatment benefits as well as the tumor characteristics.
See now where you go. It's there.
Everything okay? Everything okay? And so the treatment
No, you don't want
risks.
to download it. See? It's there. So
Yeah.
now how you going?
I don't think that's a question. I'm just continuing to go. So today's next section is about someone's lifestyle that I wanted to talk with you about, and Jeanette will talk with you about the exercise part. I will talk about it more in general, cancer survivors and their lifestyle. Some overdo it, some underdo it, and I'm not kidding. I had a few patients come in now who tell me that they're living on lettuce only because they just were not sure what else they could consume, and lettuce has barely any calories, so they were not helping themselves. And what is important to remember is that lifestyle is important, but it's not the only factor that determines one's outcome. There has to be some
slide as it'll go.
balance.
Or anything.
So I'm really sorry. I'm trying to just keep going without being distracted. So it's about finding a personalized guidance to help you maintain your desirable middle, knowing that something is better than nothing. Research has shown that even if you move in terms of exercise for at least in 10-minute increments, that already makes a difference. So if you're trying to exercise for 30 minutes a day, then the 30-minute block is really hard to find. But if you divide it into 3 10-minute blocks of time, it might be much easier to fit into your day. Most importantly, all the lifestyle recommendations for cancer survivors at this point are not cancer specific. They're generalized, derived, extrapolated from the general population. In terms of the optimal diet, that is a question I get very often, and the short answer is we don't know. There's many diets out there when you Google. Some of them are easy, some of them are difficult, some of them are expensive, some of them are cheap. But we just really don't know how they relate to each other, and in particular, how each food component relates to each other and how it interacts in terms of you exercising, for example. And so until we understand better the optimal diet for each cancer survivor, I tend to suggest moderation, variety, perhaps tend to avoid processed foods and pursue a plant-based diet, almost along the lines of Mediterranean diet, but that doesn't mean you should only eat plant-derived foods. Remember to moderate it and choose variety that includes different colors, even different grocery stores, so that maybe you're exposed to different toxins from different farmers. Many of my patients spend hours in the grocery store. They torture themselves, and I find that really, it doesn't please me to hear that. In terms of physical activity, Jeanette, the next speaker, will go into this in more detail. The recommendations are that you try to get 150 minutes of moderate intensity or 75 minutes of vigorous intensity activity. And I don't know how to differentiate the two. I don't have fancy little devices that help me with that, but the next slide includes some little tips. The difference between a moderate versus a vigorous type of activity is that for a moderate type of activity, you can talk but not sing. And some examples are here. For the vigorous activity, you can say a few words without stopping to catch a breath. And the important thing to note is that things you do in your daily life, such as grocery shopping, already counts towards exercise, and exercise doesn't have to be boring. I don't know how many of you do horseback riding, but many of my patients do dancing as a private exercise activity. So you should try to shake it up a little bit and try to have some joy in what you do, and maybe do it with other people together, which may have several flies with one stone. So care coordination can be overwhelming and uncertain. And one thing is for sure, it changes all the time. And so most importantly for you is to don't feel afraid to ask. If you're lost, if you're confused, ask your cancer doctor, maybe the nurse in their office, or even your primary care doctor. We're all willing to help you out. And remember that providers themselves are often also confused. You're not the only one, so don't feel.
Microphone is okay. Is it
So
the microphone? I guess.
We talked about all the components that pool at a cancer survivor, but the one I wanted to go to next is your healing, the non-medical part of your survivorship, which many of us forget, and that's where the green eggs and ham comes in. So I'm going to go quickly for those who are keeping time. When working too hard to make your everyday count and juggling the too many expectations that have been put on you by others, including yourself, because you don't know what or when may happen next, you may have forgotten to listen to you, and you may have lost your way. It's okay to sometimes simply be and have some downtime and allow yourself to try some green eggs and ham. I wanted to share some video clips with you, but that takes too long and I wasn't sure it was going to work. But for those of you who watched the show Madam Secretary, no political intent here at all, but season 4, episode 21 had a few minutes, around the 37th minute, I think, that was really interesting. A scene of life. They took it off YouTube, but if you can still watch us somewhere, I thought it was really, really well done. And for those of you who are interested, I can try to find it to you in hopefully a way that doesn't infringe on the copyrights. But please try green eggs and ham. Would you like them here or there? Then you can ask me, why are we doing this? And the question is, because being absorbed by an activity that you enjoy, think back to your childhood, allows an opportunity to explore existential questions, such as why are we here and what do you want to achieve? And that is perhaps a silver lining of being a cancer survivor, the post-traumatic growth, really focusing on you and your loved ones. And that is a never-ending balance that is basically an illusion to achieve. And everybody is unique. And so I hope at the end of my lecture that you feel a little bit more empowered to taking control and perspective, feel more comfortable to speak your needs or your wants, and give yourself permission to just be. Try some green eggs and ham, and that allows you to maybe come closer to your purpose and meaning in life. Last slide. Oh, here. So when will you try green eggs and ham? You may wish you had tried them earlier. To schedule an appointment with the Cancer Survivorship Program, you can do so by calling the upper phone number. That is to see me virtually, wherever you are, as long as you're in the state of Pennsylvania. And if you would like to see Kathy in person at Passivant, you can reach her at this phone number. You can sign up for our newsletter here. And the timing of all of this depends on who you are, but usually we recommend for those that have finished their active phase of treatment, their chemo, their radiation, their surgery, and they may still be a maintenance treatment, but that doesn't matter for us at that point. We are above and beyond your current providers. We don't replace anybody, and we offer access to clinical care. We provide educational activities like the one you're attending tonight, as well as we recruit for research studies. And with that, I would like to open it for questions. Thank you very much.
Dr. Van Landen, we already have a question here in the chat.
Yes.
It referred back to your slide about nutrition, and someone asked, should sugar be avoided?
I don't think avoid is, I don't think the word avoid is the word to use. I think it's pretty much unavoidable because it's in any food product that you read. I would, first of all, try to avoid, that is one thing I would say, try to avoid artificial sugars. Because who knows what is in those, and one of them was found to be cancer inducing a few years ago. If you use sugar, I would suggest use the real sugar, but less of it. That is my opinion. You can't avoid it, you can't go without, and there's a reason that we're supposed to eat all these food groups in a certain combination. So getting rid of one is hard to do. Does this help answer the question?
We have another question here regarding your reference to Madam Secretary.
Okay.
You said season 4, but they want to know which episode.
Yeah, you're funny. Season 4, episode 21.
There you go.
That is May 13th of 2019.
Great. And then we have another question here. How do you feel about essential oils?
I'm fine with those. I'm assuming you mean those oils that contain a scent, correct? Or that you use to smooth your skin. I'm not, is that what you're meaning? Or you refer to those that you put in your food to eat?
I'll wait to see if they respond in the chat. I'm assuming it's the essential oils that a lot of times that you burn in like diffusers to,
yes.
Eliminate some odors, that sort of thing.
Yeah, I'm fine with that, as well as the one that you put on your skin. With all of that though, I would still suggest moderation and variety, because some of that might become absorbed, and I'm not really sure we understand the long-term effects of it, as long as you don't soak in it for like days at a time. And the same with the ones that you use as a diffuser. There's some concern that it may irritate your lungs, in particular if you have a history of asthma, for example. Some individuals respond to that with hypersensitivity, like an irritative cough type of thing. And I'm not sure we know the long-term safety of it. So as long as you keep it within reasonable norms, whatever that means, that might be different for everybody, it should be fine to use.
Okay, Tina actually followed up with that, and she said internal oils like lemon and water, the holistic method.
I think it's okay, but I wonder if it can give you problems like diarrhea, for example. So I would moderate your usage and make sure that what you put in there is safe, because even though it's over the counter, some of those active ingredients, if that's how you call them, that you put in the vehicle of oil can do some harm. So if you're not sure, call us at the cancer center and we can find somebody who can give you an answer. Our dietitians, for example, are for free at the cancer center at Magee as well as at Hillman, and we have a traveling one that goes to all the cancer satellite centers, and they can provide you the answer that you need to feel comfortable with doing what you would like to do in terms of the active ingredient inserting into the vehicle of oil.
Great, thank you. We have one more question. What is
Okay.
what is your feeling about additional therapies, acupuncture, massage, and yoga?
I was too excited here. Yes, they're very, very good. Sorry, hold on one second. Acupuncture, the only caveat that is that it involves little teeny tiny little needles, and all of those interventions try to get to the same endpoint, which is help you relax, help you calm down. And so whichever method resonates best with you. Some individuals like a gentle massage. Some of them even like to do what we call myofascial release, where you try to relieve some of the tightness that's in your body, which is what yoga does, and acupuncture does too. So all of them are fine. All of them get to the same endpoint. Just make sure that your acupuncturist knows where you're at in your phase of treatment, so they can decide if putting needles in your skin right now, even though they're eeny meeny, are still in your best interests.
Oh,
Does that help?
Does. So Lillian has raised her hand. I don't know, Lillian, if you can hear me, would you type your question in the chat, please? Gail said thank you.
You're welcome.
So,
This is not easy.
No, but we all make it work.
Thank you.
All right. I think that's the questions for right now until we can get Lillian's question. I can reach out to her.
I think we're doing good on time, aren't we? Yes.
Yeah, we are.
Yeah.
So are we ready for?
Yep.
Jeanette, are
Yes.
you there?
I am here and I'm going to introduce Jeanette. Thank you, Dr. Van Lunden. That was wonderful and very informative. So thank you very much for that.
Thank
So
you, everybody.
Thank you. Our next speaker is Jeanette Poppenberg. Jeanette is the co-creator of Strength and Courage, Exercises for Breast Cancer Survivors. She has helped to author and currently teaches Living Life Post-Cancer Treatment with the staff at our clubhouse. Jeanette has completed research under the direction of Dr. Van Lunden and the effects of exercise on breast cancer survivors. She is the co-author of the chapter on cancer and exercise in the American College of Sports Medicine, which is ACSM. That's their textbook, and she is currently on the committee at ACSM to update the cancer exercise trainer exam. Her hope is that exercise prescription will one day become a standard of care for all cancer patients and survivors. Jeanette?
Thank you, Janice, for that introduction, and thank you for having me. I'm very excited because there actually is new information out about the dosage of exercise and how that can help us. So I'm excited to be here and talk with all of you about that today. So exercise can be a powerful medicine for your health. And no matter your age or fitness level, you can learn to use physical activity as a powerful tool to feel better. So let's talk about how we can do that. I'm hoping that after our half hour together today, that you'll be able to understand what are some of the health-related outcomes that exercise can help you with, how you can overcome some of the emotional barriers to get started, how to reap the benefits. So what do you actually have to do to get the benefits of the exercise? And as I said, we have some new information about specific doses of exercise that can help with specific health-related outcomes. I'm going to give you a couple of local resources for exercise that you can use. And of course, we're going to do some physical activity together. So exercise has been proven to reduce stress. We know it can help improve sleep. It can increase happiness. It can improve self-confidence, increase your cognitive function, alleviate anxiety, increase energy, and strengthen relationships. We have research that says that it can help us, not solve it, but help us with all of these things. So let's talk about getting started with exercise. And because we're talking about emotional health, I wanted to talk about some of the barriers that we have to getting started with exercise or being consistent with exercise. So I've listed some feelings that maybe you have had or are having and how you might solve for that. So if you're having a day when you're feeling exhausted, we talk about the cancer fatigue. And if we are talking with our doctor and we know that everything else has checked out and there's no medical problems, one of the ways that we know we can beat cancer fatigue is by pushing through. And I mean that very lightly. Push through with 5 minutes of activity that you enjoy. And that can be anything. As Dr. Van Lunden mentioned, that could be dancing, that could be walking around your house, it can be going out for a walk. Any exercise, any physical activity that you like doing, if you can push through that for 5 minutes often, you can feel better and have more energy after doing that. Sometimes when we do that, we actually have more energy and feel like doing more, and that would be great too. And sometimes it's just enough, and we just have to be consistent in doing that 5 minutes each day so that we can add to that as we go, and it will get easier. Feeling overwhelmed. Sometimes we feel like there's too much on our plate or that there's other things we're worried about, but we need to take care of us. And we need to take care of us first so that we can help our families and friends and others. So to do that, I always think about the analogy on an airplane. And you're in your seat and you're getting ready to go, and the flight attendant comes out and they talk about the oxygen and they drop the oxygen mask. And they always say to you, put yours on first before you help others. And so it's the same thing with exercise. You have to put it on first for you. You have to do it first for yourself so that you are able to help others. And again, it takes us back to that pushing through for 5 minutes. So sometimes it's just a matter of doing 5 minutes consistently every day so that you can build upon that and you can feel like you're more in control and feel less overwhelmed. Feeling helpless. Sometimes when we are alone and we don't feel like others understand, if we can move, do some type of physical activity with someone else. It might be a buddy, a friend, a spouse, a family member, or a personal trainer, because often we need help in understanding how to trust our bodies again, how to move appropriately so we don't hurt ourselves, what's normal, what's not. So often if you can work with someone, or even just as I said earlier with a friend, it will take that feeling away for you. How about if you just have a day when you're feeling bad about yourself? We all kind of have that. I wish this was different or that was different. So this is where we start to think about what are achievable goals? How do we set a goal and set ourselves up for success so we can get over that? This is where we use SMART goals. SMART goals. SMART stands for they're specific goals, they're measured, they're attainable, they're relevant, and they're time sensitive. Now, that might sound like a lot, but the difference is if I said, I'm going to exercise every day in the next 2 weeks, well, that's not exactly specific, or it's a little time sensitive, but it's a fair amount of time when you're just getting started exercise. It's not really measurable. The other way you could do it is to say, for the next week, I'm going to exercise for 5 minutes, 3 mornings. That's very specific. It's very measurable. It's should be very doable, maybe not, but you have to decide what's doable and achievable for you, but you're setting yourself up for success. You're putting in yourself in a place where you can feel good about yourself because you're doing something good for yourself and you're setting yourself up to achieve that goal. And lastly, we have feeling pain. Often that's something that comes up, right? Something doesn't feel right, something doesn't feel good. This is where I want you to start small and do what's comfortable. Exercise should never be painful. If it is, there is usually a modification for it. And so that's something that you would need to learn. And so this is somewhere where maybe you want to seek some guidance. Seek out a personal fitness trainer or your doctor, somebody that can help you and give you some direction in this area. So how do we reap the benefits of exercise? Well, first of all, starting in what's doable for you, you might want to be moving in 5, 10, 15, or 30-minute segments. We want to do this slowly and consistently as we increase our time. So if you consistently work out in a week for 5 minutes each day, you can usually pretty comfortably go to 10 minutes per day the following week. But the whole idea is to build upon this very slowly and consistently. Moderate intensity is something that Dr. Van Lunden spoke of. And the difference between moderate and vigorous. Moderate, as she said, is where you can talk and not sing. Another gauge you can use is where your body is warm, but not hot. If you're becoming overheated or nauseated, that's when you're moving probably even too far past the vigorous stage. So it's probably best to start with the moderate and use those guidelines where you can talk and not sing and your body feels warm. Another thing that's really helpful is to schedule your activity at your high energy time of day. And that's different for a lot of us. Some people are morning people, some people are afternoon, some people would prefer the evening. So you want to do it and schedule it for when you feel best. Do what you enjoy. That's really important because if you don't like it, you're not going to do it. So for some people, physical activity is not set exercise, it's cleaning their house. If that's what you like to do and you want to get on your hands and knees and wash your kitchen floor and that brings you joy, then do it. That's your physical activity. That works. That's great. Make sure what you're doing is comfortable. And if you're feeling pain during exercise, stop doing it or get the guidance you need to modify it. Reward yourself. When we always have that carrot out there, it's so much easier for us to accomplish our goals when we know that at the end, there's something that we really want. And sometimes that's just as simple as if I do my 3 days a week of 5 minutes of exercise each of those days, I'm going to give myself Friday off and I'm going to sit down and read my book because that's what you wanted to do. That's your reward. That's wonderful. And sometimes, as we talked about earlier, making it social helps. If you can do it with a friend or a spouse, a loved one, anybody that can help guide you and just make it more enjoyable. So I know this slide is big and there's a lot on it and I am going to break it down for you, but this is something that I'm so excited about. This slide just came out at the end of 2019. And this talks about the effects of health-related outcomes for those who have survived cancer. And we have the strong evidence we have and how exercise can help you with that. You may want to take a screenshot or a picture of this because it's just such a good reference. At the bottom left-hand corner is the site where you can find it if you need it otherwise. But these are things we are going to work towards. We're not going to start here because remember, we talked about getting into a consistent pattern. So you're starting with 5 minutes at a time. This is where we're going to work, what we want to work up to so we can reap the benefits of the exercise. So we do have strong evidence that exercise helps with the prevention of bladder, breast, colon, endometrial, esophageal, kidney, and stomach cancers. We also know that exercise helps with the survival of breast, colon, and prostate cancer. So how do we do that? So I'm going to take part of this chart and we're going to make it a little bit bigger for you so we can talk about where is the strong evidence and what is the exact dosages of exercise we need to work towards to make a difference for ourselves in that area. So the first one that I want to mention is, so many people talk about the cancer-related fatigue. So there are studies that we now know that when survivors do aerobic exercise 3 times a week for 30 minutes per session of moderate intensity, so again, that's talk, not sing, body feeling warm, not hot, and also, like Dr. Van London said, breaking it up into even 10-minute segments, maybe not all 30 at one time, that we have a strong outcome in being able to combat that fatigue that you are feeling. You can also combine some resistance training with that. That's going to make you stronger and help with that. With the resistance training, we want to do that 2 times per week and 2 sets of each exercise, 12 to 15 reps of that exercise for the major muscle groups of your body. So what if you just want to feel better, overall healthier, better quality of life? You could also do that with exercise. Again, we have strong evidence that tells us that 2 to 3 times a week for 30 to 60 minutes per session of moderate to vigorous exercise will help you, or the aerobic exercise. And you can couple that with resistance training of twice a week, 2 sets of 8 to 15 reps for major muscle groups at a moderate to vigorous exercise. That's just going to give you an overall general sense of well-being. Physical function, again, well-being, feeling stronger, having more energy. We know that 3 times per week of 30 to 60 minutes per session of moderate to vigorous aerobic exercise is beneficial, coupled with 2 to 3 times a week of 2 sets of 8 to 12 reps of major muscle groups at moderate to vigorous intensity. And then we get to things like anxiety and depression. We now know that in some instances, exercise can be as effective as some of the drugs that we might take for these conditions. To help with anxiety and depression and use exercise to do that, we want to exercise 3 times a week for 30 to 60 minutes per session of moderate to vigorous activity. Again, that should be any activity that you like to do, and you can break this up into segments to get it into your day. Sometimes we've referred to that. I recently heard a professor from Penn State refer to it as exercise snacks, and she takes 30 seconds just to stop and move and builds that up through the day, and it really does add up and helps you to get to that goal. And lastly, I want to mention lymphedema. For those of you with lymphedema, one of the best ways you can help yourself and help to control it is by doing resistance training. And you would do that 2 to 3 times a week, and it should be progressive, it should be slow and consistent. And when we're working out the major muscle groups like that, we know that we can help ourselves to keep lymphedema under control. So with all of that said, I want to give you some references or some resources on where you can go for exercise if you need some help. So obviously I'm right here, and I am a physiologist, a cancer exercise trainer, and I do have my exercise medicine credential. This is my email address and phone number. You are more than welcome to reach out to me in any way, and I'm happy to help you in any way that I can. Also, you can find me at our clubhouse. There's the website there. Our clubhouse is free to all cancer survivors and anyone who's affected by cancer. With the clubhouse, right now everything is virtual, although there is a physical location in the Strip District. With the virtual work, you can join online once you're a member, which there's no charge for. There are activities that you can virtually take part in every day. So I do a class with our clubhouse. Daily Dose of Exercise is there Monday through Friday at 9:30. Monday, Tuesday, Wednesday, and Friday, it's pre-recorded, so it's just a video that you would follow. But on Thursdays, I do class live, so you can join me at no charge, 9:30 on Thursdays, every Thursday throughout the year. Also, another resource that I'd love for you to take a look at and let you know about is called the One Group. And the One Group stands for Oncology, Nutrition, and Exercise. It's from the Penn State School of Medicine, and the website is on this slide. And it is a wealth of information of specific exercises to do, workouts that you can look at and follow along with. I think a lot of your questions could be answered with that too. And it's just something to follow along if you are looking for a resource. All right, so I think it is time to grab a chair and let's do some movement today. I'm going to help you reach that first 5 minutes. So if you could get a chair, one preferably without arms would be great. And we're going to move together. All right. So in your chair, if you would sit about halfway through the chair, nice and tall, our shoulders are on top of our hips. And we're going to start with some lower body aerobic work to warm up. We're going to come up to the upper body, and then we're going to do some stretching. So I want you simply to start to march in place, just having the knees coming up and down. We're trying to get that heart rate going a little bit, just a little higher than what it normally is. Warming up the muscles in the legs. This is mostly going to be your quad muscle and your hamstring. Good. And now I'm going to have you do something called out, out, in, and that's going to be more for the outside and the inside of the thighs. So step out and in. Continue to move those legs. Hope you're feeling a little warmer. Good. And relax the legs. Let's move to the upper body. We're going to reset the posture here. So if you go into a W shape with your hand, take those elbows down into the back, squeezing the bottom of the shoulder blades together, bring it up. We're going to do that 10 times. Just nice and gentle. Make sure it feels comfortable. Squeezing the bottom of that together. Keeping that heart rate up a little higher. Good. 2 more. Excellent. Reach out. Palms are going to be up. Thumbs to the back. We do that so we don't pinch any nerves in our shoulder areas. We're going to reach back, squeezing those shoulder blades together like we're going to put a pencil right between them. Nice and tall. Reach back. Just gentle movement back and forth. Squeezing those shoulder blades together. We're resetting our posture here. We've got our legs warmed up and we're getting ready for some nice range of motion work. 4 more. Good. Let's bring those arms down. We're going to lead up with our thumbs. We're coming up overhead, trying to get up as far as our ears, but just take it up as far as you're comfortable. Bring the shoulders down. Relax the arms. Let's do that 10 times. Take it up and down. Up. Good. Don't forget to relax those shoulders in between. We all tend to keep our stress there. Keep breathing. Nice deep breaths. One more. And relax. Well done. Okay, so let's go into some stretching. We're going to take that right leg out in front of us. The toe is going to be up, the heel is down from our hips. I want you to put the right hand on top of the left. Relax those shoulders, low back is at neutral. And I want you to reach towards your toe. We're reaching towards our toes just till we feel that stretch underneath our leg in the calf and the hamstring, just loosening that up. Keep those shoulders up and down. And bring it up. Good. This time, let's go down again, but let's go a little further this time, keeping that low back in neutral. Toe is up. And bring it up. Good. One more time. As far as you can go this time, keeping the low back in neutral, feeling that stretch. Excellent. Let's go ahead and switch the legs. So with the right foot flat this time, we're going to take the left out, the toe is up, the heel is down, left hand on top. From the hips, you want to come down from the hips. Don't curl over at the waist. The back is still in neutral. We're reaching for that toe. Deep breaths, relax the shoulders. Try to get the muscles to relax in that position. Feel that stretch in the calf and the hamstring behind the leg. Bring it up. Good. And again, taking it a little further. Deep breath, get it to relax. And up. Good. One more time, taking it down as far as you can go this time. And relax, bring it up. Good. We're going to go to the center this time, so I want you to sit back in your chair. Our legs are a little bit wider than our hips at this point, and we're going to roll down to release the low back. If you get dizzy or lightheaded during this exercise at all, just slowly come back up for me and stay put, okay? So we're going to start with the head. We're going to roll down and the neck, shoulders, upper back, mid back, low back. Go down as far as you can. Hang your head. Open up those hips. Mindfully release the low back. Relax in this position for a second. And start to roll it back up. We're going to stack the vertebrae one at a time here. Very mindful. Low back, mid back, upper, shoulders, neck, and head. We're going to do that 2 more times, trying to hang as low as we can. Again, if you get lightheaded, please just come slowly back up. Starting with the head, neck, shoulders, going down as far as we can. Let the head hang. Mindfully release the low back. Deep breath. And begin to roll it back up. Low back, mid back, upper, shoulders, neck, and head. One more time. Let's open up that low back and hips with the head, neck, shoulders, mid back, low back, and hang down. Release the low back, let it relax, deep breath. And begin to roll it up. Stack those vertebrae up one at a time. Come up as tall as you can. Mid back, upper, shoulders, neck, and head. Let's bring the feet and knees together. And let's bring the right ankle up. Now, I'd love for you to bring it up to your knee. If that doesn't work for you, some part of the lower leg, that's absolutely fine, but you want to cross it over. So if you can bring it up, the ankle's on the knee. My left foot is, the ankle's right under the knee, and I have a tabletop here. I'm sitting up tall with my back against the back of the chair. I'm going to push that knee down. We're going to open up the hips here. These are also really good exercises for anybody who suffers from sciatic. It tends to relieve those unpinched nerves. Come up tall, tuck the elbows in. Once again, from the hips, not the waist, come forward. This is going to intensify the stretch of the hip. Just come forward as much as you're comfortable doing. You want to go to the point of feeling that stretch and stop right there and just hold it. Deep breath, relax the shoulders. Good, bring it back up. Let's switch those legs. Left foot is flat. The ankle's right under the knee. I have my tabletop here. I'm bringing that left ankle up. Press the left knee down. We're nice and tall. Opening up the hip by pressing that knee down. Now from the hips. Tuck those elbows in, relax the shoulders, bring it forward. Keep the head, neck, and shoulders in alignment. Open up the hips, deep breath. Come on up. Feet are flat, knees are soft. We're all the way back. Let's start with the head here. We're going to take the chin over to the right shoulder, look to the side, relax those shoulders. Bring it over to the other side. Back to the front. Take the ear down to the right shoulder, stretch that neck, make sure the shoulder's relaxed. Up and over to the other side. Back to center. And let's take our chin to our chest. Stretch out that neck. And come up. Now we never go back when we're stretching out the neck because we don't want to pinch any nerves in the neck. And that's the most common place where that tends to happen. So side, down, and front are how you want to stretch that neck. Let's go to the shoulders next. Bring the shoulders up to the ears. Gently bring them down. Let's do that 5 times. Nice deep breath. Inhale up. Relax coming down. One more. Good. This time we're going to bring it up. We're going to round it to the back. All the way down. 5 times. Round out those shoulders. Let the stress of the day leave you. Beautiful. Take that right arm, take it across the front of the body. With the left hand, press that right elbow just gently towards your body so that you feel the stretch in the shoulder. Relax them down. My back is supported by the back of the chair. Good. And relax. Let's take the other arm across. With the right hand, press that left elbow in. Relax the shoulder, stretch it. And relax. We're almost there. You're doing great. Let's interlace the fingers in front of us. We're going to turn them out. I want your head, neck, and shoulders to reach out, round out the upper back, just so you get that stretch in the upper back. Relieve the tension. And pull it in tall. We're going to go 2 more times here. Stretch it out. I'm pressing my back against the back of the chair, rounding out the top of it. Bring it in. And one more time. And bring it down. One last big finish here. Come to the center of your chair. I want you to start down. This is called a chair jack. It's our big warm finish. Down. When we come up, open up the hands and the legs. Bring it all back in. We're going to do that 10 times. Everything is warm and stretched. And I hope this has helped you to feel better today. Nice deep breaths. 5 more. 4, 3, 2, 1. Nice work. So do we have some questions?
So we did, and just a reminder that if anybody has any questions for Jeanette, go ahead and type them in the chat, and we'll be able to ask her that. We did have one question during your presentation, and that was the request for that one slide that you had that had lots of information on. Are we able to get like a PDF of it and send it out to all the participants at a later date?
If technologically you all can do that, I can get it to you. Yes.
Okay, great. That was the question that we had for right now. So we'll wait just a minute or two until we have some additional questions. We did have a comment that it said, thank you, that felt great.
Oh, good.
As a reminder, if you have any questions, please type them into the chat and then we will get them to Jeanette. I know some of you were participating because we could see you on video and we could see that they were following along with you, so that was fun.
Good.
So the question from Lita Jackson says, please show the information about the one group again.
Oh, yes.
Can we get back to your slide? I think, hold on, let's see if Chris can do that. Okay.
There.
So do you want to go back there to the camera and then? So there's the slide for the one group. The next question is the CD you and the doctor made on YouTube?
It is not. It is downloadable, or you can get a hard copy version of it. And if you go to strengthandcourage.net, you can find it.
Okay. And the next question is there any exercise good for neuropathy? Yes.
That's always the big one, and that's the fine tuning of fingers and toes for so many people. So the people that I work with, what I suggest to them with the hands, we often use things that we can squeeze and work through it, keep the sensation going as much as we possibly can. So anything that you can kind of squeeze and work through your hands. The other really good one for the legs, the feet, I'm going to stand to do this. I hope you can see this. Is that you want to stand with the legs right under your hips. You want to come up on your toes, and then I often come down and rock back slightly. So that if you have just rocking back and forth, but by raising the heels, you're strengthening the calf and fine tuning all of those little tendons and ligaments and nerves in the feet, and that often brings about some more stimulation, and it can help with neuropathy as well.
Okay, let me, just to confirm, so was everyone able to see that? Because we had to switch from the screen mode to the camera mode. You want to just do it one more time? Yep.
So for the feet, you want to have the legs right under the hips, standing nice and tall. Those shoulders are on top of the hips. You're going to raise the heels off the floor, come down, bend the knees slightly, and bring the toes up. Now, you might also want to have a chair by you, in front of you, or to the side of you to help with balance if that feels uncomfortable. But just by that rocking, coming up and down, you can increase the stimulation in your feet of all the tendons and ligaments and nerves there. And I usually do that about 15 times. Often I will find myself doing it if I'm at the kitchen counter or the bathroom counter. It's just a good place if you get into habits like that of just those times. You don't have to take special time to do it. You can do it while you're going through your normal day.
Great, they said thank you. The next question is Tai Chi a good exercise?
It's a wonderful exercise, particularly for mindfulness and for balance. I think it's a great thing to do. It is very challenging on balance, so make sure you start slowly and consistently and have something by you that you can hold on to if you need it.
Great. So do we have any other questions out there for Jeanette before we take a break? I'm good. Okay.
Thank you.
You don't have to. Jeanette, thank you so very much. That was wonderful. We really enjoyed hearing that and seeing the exercises. Thank you so very much. As we mentioned, we are going to take maybe a little bit less than 15-minute break. We're going to start back up at 6:25. So if you are participating in the breast cancer breakout session, you do not have to do anything. Do not exit, just remain in this session. For the Gyne-Onc breakout session, you need to exit this session and then join us on the link that Denise provided for you. So just remember, we're going to take about 13, 14 minutes right now and join us back here at 6:25 for the beginning of the breakout sessions. Thank you so much and enjoy the rest of the day. Thank you.
Yeah, too big. See? Okay. But it's going to be beautiful. Yeah, that's beautiful with that. So,
Carol Holmes.
so you want to go yourself tomorrow?
Carol Holmes, we can hear you.
Yeah. Anytime.
Is that the same lady?
Galleria, she wants to run somewhere to buy chocolate.
That's Irene Cohen. Irene Cohen has been speaking with us.
Sitting around and all that. Whoa. Okay. Hello? Hello, is anyone there?
I'm here.
Yeah, I forgot about this workshop. I just saw the paper now. What goes on here?
Carol, it's Becky.
Becky, hey, what's up?
Yeah,
Hey.
they're on a break now, so we need to be muted, and they will be coming back for the rest of the workshop at 6:25.
Oh, okay. I know I forgot all about this. I said it started at 5, huh?
Yes, it did. So I
Oh,
don't think
darn
they
it.
want us on now. Yeah, we just need to mute ourselves and then stay muted, and they'll be coming back starting with the remainder. If you want the breast cancer one, which I think you do, just stay here. They'll be coming back on.
Oh, what did I miss?
I'll tell you. I'll call you a
Okay,
little
hon,
later.
thanks. Okay, thank you.
Okay.
we look back over the last 40 years into how breast cancer used to be treated to how it's treated now, it used to be mastectomy and one size fits all. And now the treatment paradigms or treatment strategies for breast cancer are incredibly complex and incredibly personalized. All of that is due to research.
When I talk to patients, I really try to emphasize the value of research and the necessity of research. That's what improves outcome from breast cancer.
Once I met with the doctor and seen what the options were, I realized that the way I thought they treat cancer is not the way they treat cancer. I didn't even realize there were so many different types of breast cancer. So once I sat down with him and got the options of what my choices were going to be and got all of my questions answered, I got in fight mode.
What has happened in research is that now we have understood much better which targets we have to hit in the cell to kill a cancer cell. That has been fantastic. On top of that, also right here from Hillman and Magee comes immunotherapy. Immunotherapy is a new way to treat breast cancer. So far, triple negative has been very well established to be responsive to immunotherapy, and those changes have been enormous and very, very gratifying to see that our research is having impact.
So we've had a tremendous advance in genomics and genetics, just understanding the sequence of DNA over the last 20 years. HER2 is the most obvious one, and those patients now have a different outcome than 10 to 20 years ago. That's been a revolution and was one of the first examples of true personalized or precision medicine, a unique feature of your breast cancer that leads to a unique targeted therapy specifically for you.
Virtually every question in breast cancer care has been answered not by doctors, but by patients. Patients who had the courage, when the answer wasn't no, to participate in a clinical trial so that we could get the answer, and therefore they benefited the generation that came after them.
Every single person we put in a clinical trial, whether it works or not, helps us advance the field because we're going to learn from them. We're going to learn about their specific body, their specific personality, their specific immune system, their specific cancer, all of which are different and very complicated.
Clinical trials is what makes or breaks what is new, innovative in medicine. It's what saves lives. We wouldn't be here today. I wouldn't be here today. One of the medicines I'm on after breast cancer went through a clinical trial, and they found out what worked and did not work. And here I am today, still cancer-free.
If I were to talk to one of the women that participated in a clinical trial before me, I would say thank you. What you've done at the time may not seem like a big deal to you, but look at what it's done for me. Because of what you did, I had a baby. I became a mother. So the work we do is important for the future.
So I work at the UPMC Hillman Cancer Center and at Magee-Womens Hospital because we are such a strong breast cancer program. We are one of the largest breast cancer programs in the country, and we serve over 1,200 women with breast cancer on a yearly basis. So there is so much opportunity to be able to change lives and make them better.
I really think the Hillman Cancer Center is a great place to be an oncologist. We have access to the latest treatments. We have direct access with people in the laboratory that are doing basic science research. We have a lot of collaborative efforts, not only here in Pittsburgh, but at all of the top cancer centers throughout the country. So I really feel like we're giving our patients the very best care here.
I am working to change the course of breast cancer treatment today so that we never have to worry about it in the future. And I'm working towards putting myself out of a job.
I imagine that 20 years from now, no two breast cancer patients will be treated in an identical fashion because the care for each one of them will be individualized.
I got to see the first day of kindergarten. That is something never in my wildest dreams did I think was going to happen.
By supporting breast cancer research, you give hope, you give scientific advances, you give the very best to the people who are in your community.
Area 37.
All right. Good evening, everybody. My name is Troy Trainer. I'm the director of the Women's Cancer Program for UPMC Magee-Womens Hospital, and I'm going to be the moderator for the breast cancer breakout session. Tonight, you're going to hear from Dr. Adam Brusky and Dr. Shannon Puhala, both of whom you just saw in the video there. And wasn't that a nice video? That was so well done. Again, I just want to remind you, use the comment link at the top to share any questions that you may have. And we're just going to go ahead and get started. I'd like to introduce, first and foremost, Dr. Adam Brusky, who is the professor of medicine at the University of Pittsburgh School of Medicine. He serves as the co-director of the Comprehensive Cancer Center and the medical director of our Women's Cancer Center at UPMC Magee-Womens Hospital here in Pittsburgh. He also serves as the Associate Division Chief for the Division of Hematology Oncology within the University of Pittsburgh School of Medicine, the Department of Medicine. Dr. Brusky received his degree in chemistry, cum laude from Dartmouth College in Hanover, New Hampshire. He earned his doctorate and his PhD in developmental biology at the University of Connecticut School of Medicine in Farmington, Connecticut. And he was an intern and resident in internal medicine at Brigham and Women's Hospital, Harvard Medical School in Boston, Massachusetts. He went on to complete a fellowship in medical oncology and bone marrow transplantation at the Dana-Farber Cancer Institute, part of Harvard Medical School in Boston, Massachusetts, where his appointments included associate physician and instructor in medicine at Dana-Farber. Dr. Brusky is board certified in internal medicine and medical oncology by the American Board of Internal Medicine. He is an active member of the American Society of Clinical Oncology and the American Association for Cancer Research. He has authored or co-authored numerous abstracts and research articles in leading journals, including the New England Journal of Medicine, the Journal of Clinical Investigation, the Journal of Clinical Oncology, and Lancet. Dr. Brusky is principal investigator on a number of research grants funded by the National Institutes of Health, Susan G. Komen, and the U.S. Army Breast Cancer Research Program. Without further ado, Dr. Brusky.
There, I think I'm unmuted now. So thanks a lot. And let me try to kind of just gain control of the screen here because I'm doing this separately. And let's get this going here. So I hope you guys like that breast cancer survivor video that we showed about all the research. And, you know, I think what Dr. Puhala and I are going to do for the next hour is just kind of go over clinically and kind of from a research standpoint where we are in breast cancer. And I think the biggest thing I want to emphasize is we're going to go through a lot of data. You know, don't kind of try to understand it all. We'll ask questions at the end, you know, answer anything you have, any questions you have about this stuff. But I think what Dr. Puhala and I want to kind of give you guys is a flavor for the fact that, at least in terms of metastatic disease, we're turning to something more chronic. And in terms of early stage disease, I think we're curing more and more people. And I've been doing this 25 years. I've kind of been in charge of the breast program here for about 23 of my 25 years here at the University of Pittsburgh. And I haven't left, and I haven't left for a good reason, and that's because, you know, just being part of Magee and being part of the NSABP and all these clinical trial groups, and you know, we really have changed. I really have been very fortunate to have seen this field change dramatically, and it's going to change even more dramatically in the near future. So with that, let me just kind of go through some slides. And, you know, again, these are kind of a lot of slides that I give people to docs. And so, you know, don't feel like you have to understand all of it, but I just want to give you a flavor. So the first thing to really talk about is triple negative breast cancer. And this is breast cancer defined by an estrogen positive, HER2 positive, breast cancer defined by either being estrogen positive, HER2 positive, or neither. And that's triple negative breast cancer. But triple negative breast cancer is driven by a lot of different things. By, you know, if you have a mutation in BRCA1 or 2, that's one kind of triple negative breast cancer. If you have a breast cancer driven by, say, you know, the immune reaction to it or the lack of immune reaction to it, that's another kind. And then there are growth signals that drive triple negative breast cancer. And so what we've learned, and we've learned all this over probably the last 5 to 10 years, and what we've done is we've taken that knowledge, at least in triple negative breast cancer, and tried to manipulate triple negative breast cancer based on our knowledge of all this stuff. And so the first kind of thing that you hear about is immunotherapy. I mean, it's like a hot topic, especially in lung cancer, melanoma, and some other cancers. And what we try to do is we try to get the immune system to react to the cancer. And, you know, when you think about it, women in particular, you know, kind of have an immune system that's important. Why? Because a lot of you, if you've had children, and even if you haven't, you have to be able to tolerate a fetus in your body, for 9 months. And so therefore the immune system in women is going to be a little bit different than it is in men. And what's really interesting is that, you have a particular immune system that's kind of driven by estrogen that you have in your body, and then you become postmenopausal, and suddenly the immune system kind of changes a little bit. And a lot of us are starting to believe that that's that change. We thought it had a lot to do with the hormonal therapy that you do that maybe stimulates your breast to grow and breast cancer to grow. And that's probably true. But in addition to that, what probably is happening is that it's messing up with your immune system. It's kind of messing around with it. And that allows breast cancer to grow. And so the whole idea that we have now, especially in metastatic breast cancer and triple negative metastatic breast cancer, is that we give drugs that are called checkpoint inhibitors. And what these do, they stop kind of your immune system from being suppressed, because the natural way your immune system is to be suppressed, because if it wasn't suppressed, you get autoimmune disease like lupus and things like that. And so the whole idea is to kind of give drugs to block that suppression, turn the immune system on so it can fight your cancer. And these are just a couple trials that have been done. There's one called Impassion 130, and this trial took a drug called atezolizumab and gave it with another drug called Abraxane, which is similar to Taxol. We give Abraxane all the time with people, who have metastatic breast cancer. And this just shows you, that, again, when you look at these curves, it doesn't look great. But on the other hand, what you can see here, is that you clearly have improved these progression-free survival in these ladies who got this. And that means that the women live longer without it coming back or growing further. But what's also really important is that they survive longer too. And I think, again, don't get too caught up with the numbers, but the fact that you have all these people out here now 3-4 years later who got this first line. And normally, a lot of these people who had triple negative breast cancer, would not do very well. So you're actually almost doubling the amount of time these ladies have survived, that you've survived with triple negative breast cancer with a checkpoint inhibitor. So it's really exciting. That's just one of them. There's another trial that was just presented at this year's ASCO meeting. It was called Keynote 355, and it's a different drug called pembrolizumab. And so the whole idea here is that, we want to be sure that this works not only with atezolizumab, but a drug called pembrolizumab, which is a drug very similar, but it's a little bit different, but it still acts on that same way. It binds to this protein called PD-L1 that kind of actually turns your immune system on. And again, in this trial, the same thing happened. The progression-free survival was basically improved by a lot, by in this case almost double, from 5.6 months to 9.7 months. And I think that's really important, because again, there's a lot of people, 30-40% of the people here, at least 30% of the people, you're now out, 2-3 years, they really do really well. And that's what we're seeing with immunotherapy, is that, a greater percentage of people, when you respond to it, you tend to respond a really long time. And I think that's really important. And that's just telling us that in a certain percentage of people, we're turning this into a chronic disease, which is really, really important. And I think it's something that, we need to know, because again, the whole concept here is to take something that was rapidly progressing, could cause a lot of problems in somebody, and turn it into something that's a little bit more chronic. And I think we're getting excited by that. Then we want to add this to other drugs. So, this is a trial now with people, who had progressed, say they were on, say, their therapy and they progressed very quickly, say it's only 6 months after they completed their adjuvant therapy, their early stage therapy for early stage breast cancer. And so we wanted to try a different drug. And so we have a trial going on right now. If anybody's interested, if we have people who have triple negative breast cancer who progress fairly quickly, what we're doing is we're giving them 2 drugs called carboplatin and gemcitabine, and we're giving with or without a drug called atezolizumab, which again is this checkpoint inhibitor. So there's a lot of really interesting stuff going on with immunotherapy. There's also we have something with another drug called carboplatin and pembrolizumab, and that's for people who have a disease that's in the wall of their chest, a local recurrence, really bad local recurrence that we can't resect. So that's one option. So that's triple negative breast cancer that's metastatic. What about manipulating the growth pathways of cells? So there's these compounds, these drugs called AKT inhibitors. And so the whole idea is that there's this whole pathway that we've worked out of all these proteins that actually kind of work in the cancer cell. And so there's all these areas. So there's something called PI3 kinase. We're going to talk about it a little bit later. This drug called alpelisib. There's this drug called mTOR. There's a drug called everolimus that people are on, Afinitor that we usually use. Or there's this protein called AKT that seems to be very important in this pathway. And there's drugs called capivasertib and ipatasertib that actually block it. So if you can block anything, in this pathway, you can kind of stop the cells from growing. And there's a lot of other things that these things do that we're just learning, but at least for now, that was the hypothesis we had when we started to do this. And again, there was a trial where we took women who had not had prior chemotherapy for their metastatic breast cancer. They had triple negative breast cancer, and we gave them paclitaxel, which is a standard therapy, but we gave them capivasertib on top of it. And we also looked to see whether they had a mutation. What we can do is we can actually take your blood and look for circulating cancer cells in your blood and do DNA sequencing on them. And if they have one of these mutations, then you're eligible to get this drug capivasertib. And so, in fact, this is what happened. That basically we took people who had one of these genes mutated, and they actually had a much longer, you can see here, progression-free survival. And in fact, even an overall survival, again, 30 months later, very small trial, but 30 months later, over half of the people were still doing pretty well from triple-negative breast cancer that was metastatic. So this is really important. You know, again, we're building on it. There's a large trial going on now that we've just started called Capitello. It's 800 people all around the world where we're giving them this paclitaxel drug. It's standard chemotherapy that you get for triple-negative breast cancer. But what we're doing is we're adding this drug capivasertib to half of the people. And so we're going to see what happens. It's a really nice trial. And I think it's open in the community, you know, for people who just were diagnosed with metastatic triple-negative breast cancer. But what I think is really, really cool is something that we played a major role in. We were one of the, and actually our group is going to be on the paper that's going to be in the New England Journal. We think it's going to be published in the next couple of weeks, about probably a month or two, actually. And that's a magic bullet. And what it is, it's an antibody that has a little bit of chemotherapy on it. And so it binds directly to the cancer and nowhere else. And so this is called sacituzumab govitecan, or Trodelvy is a name. And what it is an antibody to this protein called TROP2 that's expressed on all triple-negative breast cancer, and in fact, some estrogen receptor-positive breast cancer. And what they've done is they've added chemotherapy molecules, this SN38, which is a chemotherapy, and they added it to the sacituzumab govitecan. And we were involved with this company when they were only 2 people. And in fact, now they're about 1,000 people, and they were sold to Gilead for $21 billion. So, you know, Magee had a real play, you know, real involvement with this company from the beginning. Immunomedics who made these drugs. But the bottom line is that there was this trial. It's not confidential anymore. It just says confidential under now, but because the trial's been presented. But the bottom line is that they took women with metastatic breast cancer. And in fact, these were people who had already had a couple chemotherapies already. So you already had your metastatic breast cancer, but then you had like 1 or 2 chemos. Now you're on your 3rd chemo. And usually people don't respond that well when we do that. And so what we do is gave them the physician's choice of whatever chemo, you know, we had. You know, it could be various drugs, or we gave them the sacituzumab. And what's really cool is that the progression-free survival you can see here was really improved dramatically here. It doesn't seem like a lot, but it is. You know, you really improved it by about 60%. And again, you had people that really hadn't progressed, you know, a lot out here almost at a year, you know, where most of the people is only 1.7 months. Most of the people on the standard chemo, it didn't really work. But what really blew us away is that the overall survival of these people were doubled. So literally, you had people who had been through a lot of stuff, and you know, when docs will go to you and they say, "Listen, you have triple-negative breast cancer. You know, we have chemo, but it may not work that well anymore." But on the other hand, now you have something that has doubled your overall survival, and I think this really has never been seen in triple-negative breast cancer. And the drug is fairly well tolerated. You do lose your hair, you get a little bit of diarrhea, your white count goes down a little bit, but there's no nausea. And I've had people on this a drug for 2 years already on the original trial. And so this is really, really big. And I think a lot of us are using this now in our practices at Magee. It's now standard of care. It was approved by the FDA about 2 or 3 months ago, I think in June. So the next thing to talk about is HER2-positive metastatic breast cancer. And I think, you know, the big news over the last 20 years is that we have this drug, trastuzumab or Herceptin, and we give it with another drug called Perjeta or pertuzumab. And we give that with chemo, and in the first line, it does really well. In fact, it turns out the median survival now is over 5 years, which is really dramatic. And in fact, 1/3 of the people actually live longer than 8 years. And in fact, we believe it's now upwards of 50% of people who now get these drugs could live up to 8 years, if not longer, which is a lot, you know, for breast cancer. Clearly, we want you to live for a long time, even longer than that. But that's a really big deal. We also have another drug called TDM1 or Kadcyla that we use when trastuzumab, when the first-line regimens don't work. You know, so that works really well. It also improves the overall survival fairly dramatically. So, you know, we really have a lot of really great stuff for you that can keep people going for a long time with this disease. Clearly, but we want to do better. It's not enough. I'm not happy with 5 years, 8 years. I want 10 years, 15 years more. And so, we really thought long and hard, a lot of us, about what to do in the third line and beyond. And what tends to happen in HER2-positive breast cancer is that it has a tendency about 50% of the time for people to develop metastasis to their brain. And so what we want to do is we want to prevent that from happening. And so, or we want to treat it. Or we have other new magic bullets, a drug called Enhertu I'm going to talk about too. But again, there's a drug, I think first of all, what we can do is we can add these drugs called tyrosine kinase inhibitors. There's a drug called neratinib or Nerlinx that we use. And this drug actually was tried versus standard trastuzumab, just as therapy of metastatic breast cancer that was HER2 positive. And what was really dramatic here is that the number of people who had disease in their brain fell by half. And so we knew by these old trials that when we did this, that if we treated people with these, what we call tyrosine kinase inhibitors, these HER2 tyrosine kinase inhibitors, we can reduce the amount of disease in their brain by half. And this is a pretty big deal because this is the biggest problem now that we have, that women are doing so well that disease can recur in their brain. So we're trying to block it by doing all this stuff. And so there's a trial called NALA where we use neratinib and capecitabine, which is a chemotherapy, versus a drug called lapatinib, an older drug, and it improved the progression-free survival. It kind of improved also, it reduced also the amount of time that people have before their brain mets recur. So again, this is all building now. We have these drugs that get into your brain that may block brain metastases from happening if you have HER2-positive breast cancer. But what's really cool is we have now actually other drugs. So neratinib, its biggest problem is it binds to this other protein called EGFR, the epidermal growth factor receptor. And because of that, you get a lot of diarrhea. So there's another drug that was just developed called tucatinib or Tuscaya, where basically it's HER2 positive, it binds it, but it doesn't bind to this colon, so you don't get diarrhea, and it works really well. So there's a trial called HER2-CLIMB that just got presented at our national meeting, was published again about 9 months ago, where people got trastuzumab, capecitabine, and placebo versus trastuzumab, capecitabine, and tucatinib. And I just want to focus on the brain met part of this, that the people that just got the trastuzumab and capecitabine, almost all of them had their brain metastases progress, but fully 40%, almost half of the people, didn't have a progression of their brain metastasis at a year. And so this means we're making a dent in what's happening in people's brain metastasis. And in fact, it resulted in even an overall survival. The overall survival went up. I mean, 70% of the people a year later who had brain metastases from breast cancer that were progressive actually were alive and doing fine. And I think, and again, we want this to be forever, but this is definitely a major advance here. And I think we're all very excited about it. And the other thing that's kind of interesting is that in this trial, they gave you a choice that if you had a brain metastasis, you could get radiation or you could do this trial instead. And then do the radiation later if it didn't work. And in those patients, fully 35% of them avoided brain radiation for a year. And again, this is a big deal because this means that we're trying to avoid a therapy that can give you toxicity to your brain. And I think this is really important as well and improve their overall survival. So we have a trial now where people actually have what's called lymphangitic spread. That is that the disease is spread not to the brain itself, but to the lining. And it's something that's pretty severe. And so what we're doing now is treating people with tucatinib, capecitabine, and trastuzumab together to try to prevent this and treat it. And I think it's going to work. It already has worked already. Someone has a trial open at MD Anderson, and it seems to be working somewhat well. And so we're really now taking something that's really serious. Breast cancer is really serious, metastatic breast cancer is really serious, but to have it in lining your brain is very serious, and we're actually being able to make a dent in it. This is the excitement of this sort of thing that's happening now. What about other things? Well, there's a drug. This is now another magic bullet. You take the trastuzumab or Herceptin. In this case, you add a drug called trastuzumab. You add deruxtecan to it. It's a chemotherapy. And so this will bind all HER2 positive breast cancer and then basically release this inside the cell and kill it. And in animal models, you can see here, it does really well by reducing breast cancer. And so we figured it would work in people. And in fact, this is a phase 2 trial where people had a ton of chemotherapy, a ton of Herceptin. They had like six different regimens. So they're like 6 line on average, and they're given this drug. They're given the drug, this is called trastuzumab deruxtecan or Enhertu is the name. And in fact, you can look at this. This is what we call a waterfall plot. Almost everybody responded. This is a decrease in their cancer burden, and almost everybody, a few people even had a complete response here. And the interesting thing is, it lasted over 16 months. And the median overall survival wasn't reached yet from this drug. And so this is now, as I'm going to show you, in a big phase 3 trial. They're comparing it to the TDM1 in one study, and they're comparing it to chemotherapy in another. This is a big phase 3 trial. These trials have been completed, and we're going to find out the results of them probably in about 3 to 6 months. But Enhertu's been approved by the FDA on the basis of those dramatic results. And, really, we never expected people to basically have 70 or 80% of the people still not progress, still be alive, after 6th-line or 7th-line therapy for their breast cancer. I think it's great. It really is something we think that's going to change the way we treat HER2-positive metastatic breast cancer. And in fact, it's also interesting is that you could take people who don't have HER2-positive disease, either triple negative or estrogen receptor-positive disease, and actually just have a little bit of amount of HER2 on it, not enough to qualify for Herceptin or something like that. And actually they respond as well. So there's a really nice trial that literally we put a bunch of people on. It just finished. It's for people who had estrogen receptor positive or triple negative breast cancer and had a little bit of HER2 on the cell surface, what we call 1+ or 2+. And what we did is we gave them this DS-8201 drug that is the Enhertu or regular therapy, and we're going to find out the results of this. And we think it's going to be pretty exciting. So we're very, very excited about this and to see where it's going. So the last thing I want to talk about in the last 5 minutes or so, or 10 minutes of this, is estrogen receptor positive metastatic breast cancer. And I'm going to show you in a minute, we have these drugs called CDK4/6 inhibitors that really have changed this disease completely. It used to be that you had metastatic breast cancer, say to your bone or to your lungs or to your liver, that was estrogen receptor positive, and we would treat you just with hormonal therapy, like say an anastrozole or letrozole or a drug called fulvestrant, and then we would just treat you on a series of hormonal therapies, eventually give you chemo. But we added these CDK4/6 inhibitors, and it literally has stabilized the breast cancer people for years on average. I mean, it's a median of 2 to 3 years now that you can do really well. Not everybody, but a lot of people can do really well with hormone therapy and CDK4/6 inhibitors. And so really, we're really excited about it. But what's really important is that what do we do after that? I mean, I'm not happy with 3 to 4 years. I don't think you should be either. I want more. I mean, I'm greedy. Before I retire, I want, this to go out 10 years. And so we're more. And so the thing is that we now are trying to figure out what to do afterwards for estrogen receptor positive metastatic breast cancer. And clearly you can give chemo, and there are lots of new chemos. There's oral chemos that you don't lose your hair with that we've developed now. Besides capecitabine, there's something called tezactaxel. But there's other options too that we're going to have. And just to show you, you don't have to, this is like basic science stuff, it's just how these things work. They kind of block the way the cancer works, in other words, by blocking kind of the cell cycle from happening. But the bottom line is that we have 3 different ones of these. We have palbociclib, ribociclib, and abemaciclib. And they all of them are available, and they all kind of work basically the same way, but all of them, regardless, double the progression-free survival. It doesn't matter. And this goes out to actually, you can see here, 2 years, 3 years in some cases. You're doubling the progression-free survival, so you're doing pretty well. So, what do we do afterwards? Well, there's a protein called PI3 kinase that I talked about before, and about 40% of estrogen receptor positive metastatic breast cancer has PI3 kinase activating mutations. And so we now have these PI3 kinase inhibitors that actually block the PI3 kinase. In particular, one of them called alpelisib, or Piqray, was approved actually a few months ago, actually about a year ago actually, on the basis of this trial called SOLAR-1. And what we did in this trial is we took people who had progressed to an aromatase inhibitor, and then if they were PI3 kinase mutated, we gave them either fulvestrant, which is a hormonal therapy, with or without alpelisib. And basically, we saw what happened. And you can see here that the alpelisib doubled the progression-free survival from about 5 months to about 11 months, which doesn't seem like a lot. But again, looking at it about 2 years, a lot of people had not progressed and are still doing pretty well. And so, the major side effects of this therapy is that the major side effects of this therapy are basically that you can get high blood sugar, which you control with metformin, and a rash, which you control with Zyrtec. So people are doing pretty well with this. And I think, that I'll give you about 20 minutes to give you a flavor of what's going on. But I just wanted to give you a brief summary of the many exciting things that are happening in metastatic breast cancer treatment and research. And I think that what we're really trying to do is turn this into a chronic disease like hypertension, diabetes, something you can live with for many years. It's still very, very serious. We're not underplaying that at all. But I think in the 25 years I've been doing this, I've been really fortunate to kind of see metastatic breast cancer being turned into something that's now more of a chronic disease, not an acute disease. And I think using things like genomics and a better understanding of the immune system in breast cancer will bring us even more exciting things in the future. So with that, I'll kind of end and I'll kind of try to get out of this. I hope you were able to hear me this whole time. Hello, is someone there?
Adam, can you hear me?
Yes.
Okay, we're going to wait to see if anybody's going to post any questions in the chat. And but I did have one person who made a comment just thanking you for sharing the information about the brain mets and saying that this is outstanding news.
Yeah, it really is. I mean, you know, I went through a lot of stuff really quickly. I mean, it's more easier for me to take questions from people, you know, about all of this. And I think that, you know, the important thing is that I think, and the big new thing that's really going to have brain mets are great. And hopefully we have these things out of control. And we're learning a lot more about how brain mets actually get into the brain. It's not exactly what we thought. And, you know, there's a lot of stuff I can't talk about just yet about how we kind of, I think people at Magee, actually, we worked this out, believe it or not, with a pharmaceutical company. We think we may be able to someday predict who gets brain mets and who doesn't, and to be able to direct the therapy to them. But that's, you just can't talk about that much. It's still too early to talk about that stuff. But I think the bigger thing is we're going to learn how to control the immune system. I think that, to me, at least, that's where I'm going to, at least as the director of our program, I'm really going to move our program. I've told everybody this. I'm moving our program more in that direction to really have us try to understand, you know, what the immune system is really doing, especially in women. Women's immune systems are definitely different than men's. And, you know, so therefore there are some unique features to the immune system of breast cancer that we need to learn about and I think exploit, and then we're doing that. So, you know, we're learning more and more about it. And the things you're going to find out about in the next 2 to 3 or 4 years are really, really cool stuff. And so, you know, again, metastatic breast cancer is still a serious, serious disease. Don't get me wrong. You know, I've been treating it for 25 years. But on the other hand, you know, I think there's just so much reason for hope now for people that we didn't have even 3 or 4 years ago. Just things that can extend your life, make you live better, you know, just like you saw in that video, you know, who's from one of my patients, just being able to go to, you know, your kid's graduation or your kid's first kindergarten day, you know, things that you never would have expected even 3 or 4 years ago. So I think it's just a really exciting time to kind of be doing this.
Adam, we do have a question. Someone asked about, are there studies for ductal and lobular?
Yeah, so there are. So, you know, it's really interesting. And that's another thing we're really specialized here at Magee. Steffi Osterreich is like a world expert at lobular breast cancer. And so the thing is that lobular breast cancer, ductal and lobular, we thought for the longest time kind of behave the same way. Ductal cancers are, ductal means it's of the milk ducts. The ducts actually take the milk to your nipple. And lobular is actually lobules that make the milk. And for the longest time, we felt they were pretty similar. But Steffi and a lot of other people have kind of done a lot of the really interesting genetics on this. And they clearly are different cancers. They kind of spread a different way throughout the body. They tend to go kind of throughout your abdomen or your stomach or to your ovaries if they have metastatic disease. And so, you know, there may be some slight differences or even major differences in how they respond to chemotherapy. And so, you know, we do have a few trials for, and I think Dr. Puhal is going to talk about this, you know, she may or may not, about kind of trials in early stage lobular cancer, trying to see kind of manipulate it with various different hormones and see what happens to it genetically. So, you know, but at least in metastatic breast cancer, we don't have particular lobular trials. Those are more for the early stage breast cancer.
We have another question. Are all of these treatments for metastatic breast cancer? Is one question. And then the second question is research being conducted for stage 1 and stage 2 breast cancer treatments.
So, all right, so let me take them one at a time. So the neratinib that we talked about is actually, we just literally, I was just talking to people this morning, we literally just published a paper, I think last week or 2 weeks ago. It improved survival in early stage metastatic breast cancer. So early stage breast cancer. So suppose you have a HER2 positive breast cancer, right? We give you chemotherapy and trastuzumab, pertuzumab, we call it neoadjuvant chemotherapy. And if there's residual cancer left over, we give you another drug and we give you TDM1 or Kadcyla. But it turns out we actually have data now. If you get neratinib, it improves your survival even more. You do really well. It's over 90% of people live who get this therapy anyway, but it could raise it even higher, maybe up to 92, 93, 94%. Anything is better. And it probably does that by preventing you from getting brain metastasis. At least that's the theory. So that's one drug that's being used early on. We have a lot of trials of some of these other drugs. Just now, for example, one of the CDK4/6 inhibitors, a drug called abemaciclib, was shown to improve prevent relapse in women with estrogen receptor positive early stage breast cancer, but they have lymph nodes involved. So the problem is that people do so well with stage 1 and 2 breast cancer. I mean, we're talking now, if you do it right, over 92, 93, 95% overall survival at 10 years now for a lot of this, that we don't have a lot of trials. We're trying to figure out how to do it now, because to do a trial in stage 1 or 2, because people do so well, you need tens of thousands of patients to see a difference. So, to do the sort of trials, we got to get people from all over the world together thinking in the same way. And the problem is that the pandemic now, we're all kind of focused on that temporarily until it ends. And so, we're trying to build these huge coalitions of tens of thousands of patients to try to answer some of those questions. So that's a great question. We would love to have trials for stage 1 and 2. We used to have them all the time. In fact, that we were the biggest accruers nationally on a lot of those studies. But what happened is that A, people are doing so well, and B, to do a trial now, you need 5,000 or 10,000 people. So, you got to get a lot of people on board. It takes a couple of years to kind of build something that large. That's a good question, though.
Okay, that's all the questions that we have for right now. You were getting a lot of comments just about how passionate you are and people thanking you for the research that you're doing.
Well, you're welcome. No, it's you guys. You guys is for you. And you guys are the people who do it by participating in studies, by coming to clinic, by, just doing what you're doing. I just am fortunate to be able to be part of it, but it's really for you guys. And as we said in that video at the beginning, it's really important. Clinical trials are actually the cutting edge of our business. You're not going to get anything but the standard of care at a minimum. And most likely you're going to get what the standard of care is going to be 5 years later. So anyway, good. Thanks.
That really was wonderful. Thank you very much, Dr. Brofsky, for engaging us and letting us know what's going on in the world that you're working with. I'd now like to introduce Dr. Shannon Puhala. Dr. Shannon Puhala is a medical oncologist who has been at UPMC since 2007. She is a board-certified medical oncologist who maintains a busy practice, specializing in breast oncology here at UPMC Magee-Womens Hospital. She's also part of the National Surgical Breast and Bowel Program, or NSABP operations, helping to conduct international breast cancer clinical trials. Dr. Puhala graduated from Northeastern Ohio University's College of Medicine. She performed her internal medicine residency and hematology oncology fellowship at the Ohio State University Medical Center. She was appointed as breast cancer fellow. Puhala's dedicated training in the design of breast cancer clinical trials and the care of breast oncology patients. She's the principal investigator on many NCI and pharma-sponsored phase 1 and phase 2 clinical trial cancer trials focused in breast cancer. She has funding from the National Cancer Institute as well. Dr. Puhala is a published author in key medical journals, including the Journal of Clinical Oncology and the Journal of the National Cancer Institute. Dr. Puhala.
All right, great. Can everybody hear me?
Yes.
All right, wonderful. And Troy, do I show my slides? Do I share my screen and show them?
Yes.
Okay, perfect. Let me just get that going here. Okay, and we'll do slideshow from beginning. Okay, great, thank you. And Dr. Brofsky and myself, we'd kind of touch base briefly to figure out how we wanted to divide this up, because luckily there are so many exciting options that we have for our patients, new drugs, new data, and this talk is constantly changing. You can't ever give a research update talk and use your slides from the year prior, which is a really wonderful thing. So I just wanted to briefly mention two things, one of which is Dr. Brofsky, his focus was on patients with more advanced disease or metastatic disease. And I know one of the questions came in about early stage disease. So that's what I'm going to be focusing on here with my portion of the conversation. And I can actually show myself too. Okay, great. So one thing to mention is, how do we know that things work? And whenever I give one of a talk to patients or survivors or people who are living with cancer, I think it's important to understand how we determine how well drugs work, because it becomes very kind of confusing when you're looking at different research papers or different studies that have come out to understand just how does a drug working mean. So ultimately, how good is good? And many times when you're looking at these clinical trials, you see a lot of these terms. So the things that I think are important to have an understanding about, it's absolute benefit versus proportional benefit. So absolute benefit is a percent out of 100 people, how many more people lived or didn't have their cancer come back because they got a specific therapy. Whereas proportional benefit is looking at kind of something we call the hazard of something happening. So when you hear that maybe there's a 50% reduction in return of cancer or a 20% reduction in return of cancer, that's more of what we consider to be proportional benefit. The way that we define response is that the tumor has to shrink more than 30%. And then the response rate is the amount of people in the study who had their tumor shrink to that degree. Stable disease is defined as that there's a range where the tumor can grow a little bit, or it can shrink a little bit, or it can stay stable, and that's considered stable. The response rate, again, is the percentage of people in the study who responded to a specific treatment. Recurrence-free survival is the amount of time that somebody lives after getting a certain treatment without a recurrence coming back. And sometimes you'll see us talk about breast recurrence versus distant recurrence. So those are certainly different variables that help us understand how well a treatment works. And then progression-free survival, we actually use this a lot in the stage 4 setting, which is how long somebody is able to stay in that response without things getting worse. And really our gold standard in oncology is how long do patients live? So do people actually live longer, and absolutely importantly live better because they got a specific treatment? So if you have any questions about this terminology, certainly feel free to ask me or Dr. Brufsky if he's still on the line, and we can help kind of understand how to look through these clinical trial results and scientific paper results. So we mentioned these a little bit in the last talk, and these are drugs called CDK4/6 inhibitors, and they have very nice commercials. So you may have seen some of these come up as you're watching the news in the morning or watching TV at night. But right now there are 3 that are commercially available: palbociclib, which is also called Ibrance, abemaciclib, which is also called Verzenio, and ribociclib, which is also called Kisqali. And the way that these drugs work is they inhibit cancer cell proliferation by blocking cell cycle progression. So this is just a little schematic here of what goes on in a cancer cell. So this area down here is the actual cancer cell itself. Here's the cell membrane. So this is kind of outside of the cancer cell. And there's different factors that stimulate cancer cells to grow. So there's different growth factors. This is cut off, unfortunately, but this says estrogen. So estrogen goes into the cancer cells, turns on the estrogen receptor signaling. These growth factors also go into the cancer cells and turn on cancer signaling. But what's important here is this molecule here, CDK4/6. And these drugs, they block this from happening. So the idea is that when those enzymes are blocked, that those cancer cells are not growing and dividing. So currently, all 3 of these drugs are approved in patients with metastatic or stage 4 disease, and they can either be given with aromatase inhibitors like Arimidex or Femara, or they can be given with fulvestrant, which is an injectable anti-estrogen medicine that we use in stage 4 patients. But there were a number of clinical trials that were ongoing in early stage disease, and we participated in many of these studies at Magee, and maybe some people on the call here were a part of these clinical trials. And there was recently a clinical trial called the Monarch-E study. And this is a study that we are extremely excited about, and I do think this will change our standard of care for how we treat patients with early stage disease who meet these criteria. So in general, what we do in oncology is we find drugs that work really well for patients who have stage 4 disease, and then we move those drugs into the early phase setting. So the idea is, well, maybe if we give these medicines to people who have stage 1 or stage 2 or stage 3 disease, can we lessen the chance of their cancer coming back or spreading or showing up somewhere else in their body? So with these drugs that have worked so very, very well in stage 4 disease, the next set of studies move them to early stage disease. So this particular study here was done with abemaciclib or Verzenio. And the patients who were able to participate in this study were defined as high risk. And I'm going to talk a little bit later about why this particular feature is important. So what was defined as high risk in this study were people who had 4 or more lymph nodes positive, or they could have 1 to 3 lymph nodes positive, but their tumor had to be at least 5 centimeters, grade 3, that's the Nottingham grade you've probably seen on your pathology reports, or the Ki-67 or the proliferation index had to be over 20%. So these were, you had to have these criteria present in order to be part of the study. So the study enrolled women and men. As we know, men are unfortunately can get breast cancer as women, although obviously women are the population that we see more commonly. In this study, patients could be pre or postmenopausal, and they could have prior chemotherapy, or sometimes they may not have prior chemotherapy depending on other treatments available, but they could not have metastatic disease. So you'll see this study enrolled over 5,000 patients. Like Dr. Brefsky just mentioned, when we're doing a study that's more of a prevention of recurrence study, they need to be much, much bigger for us to see these treatment effects. And in this study, patients received the abemaciclib or the Verzenio for up to 2 years, as well as their standard endocrine therapy. So this could be your tamoxifen or your Arimidex or your Zoladex shots, or patients just got standard of care endocrine therapy. So a really important point is that very rarely do we give no treatment in oncology trials. So just important to know that the standard of care, that's the treatment somebody would be getting anyways. So this is if they would be getting Femara anyways, or they would be getting tamoxifen anyways, you always get that treatment. But some people also got the experimental drug, and this was a 1-to-1 randomization. So half the patients got the standard hormone therapy, half the patients got the abemaciclib. And the thing that they were looking at, or what the primary objective is, the primary goal of the study was to look at invasive disease-free survival. So did the cancer come back in an invasive way? So if it came back as non-invasive or as DCIS, that was felt to be okay. But the question is did it come back as invasive disease? And then specifically with that, they looked at distant relapse-free survival. So the chance of the cancer coming back somewhere else in the body. So we found, and we looked at these curves in Dr. Brefsky's talk, but basically we want to see a separation. It's important to note the time frame. So this is within 2 years, and we know unfortunately sometimes folks who have breast cancer can recur 5, 10, 15 years later. And what you can see is that the longer that time goes by, these two curves start to separate. And what they found in this study was after just 2 years, there was a difference in these two arms. So people who received just the hormone therapy by itself compared to people who had the abemaciclib added to the hormone therapy had less chance of the cancer coming back. There were less events in that arm. And the way that we determine this is something called a hazard ratio. So that hazard ratio was 0.747. So what that means is that this reduced the risk of invasive recurrence by 25%. The other thing that's important when we're looking at a clinical trial is, was this statistically significant? So did this result happen by chance, or did this result happen because of a real treatment effect? And typically anything that is lower than 0.05 is considered significant. So you can see that it met that criteria. So again, this number appears to be small, But what that translates into is a 25% lower risk, which is significant. And it's also important to note that this is at 2 years. So what we anticipate is the longer that this data gets followed out, you're going to see more and more difference over time. The next thing that this study looked at was distant relapse-free survival. So what's the chance that the cancer is going to become metastatic? And again, there was a 3% absolute benefit, which translated into a 28% lower risk of the disease becoming metastatic. And this also was statistically significant. Now, what about side effects? So it's always nice when things work and they don't have side effects, but certainly there can be side effects when you add additional treatments. And what you can see here, and just eyeballing this chart, people who got just the hormone therapy had low chance of side effects versus patients who had the abemaciclib, you can see much higher rates of side effects. So this is the percent of people having a side effect. And certainly these blue bars are much taller than these orange bars. However, what's important to note is that most of the side effects were mild. So grade 1 means that you have it, but it doesn't interfere with function and you don't necessarily need to take anything. So for instance, if someone has grade 1 nausea, maybe it just goes away with drinking a glass of ginger ale, something like that. Now, one of the big side effects you have to be aware of with this Verzenio or with abemaciclib is diarrhea. So you can see up here on the diarrhea bar, there was a decent amount of grade 2 and a little bit of grade 3. But what's important to note about this is that the diarrhea does improve over time, and only about 5% of patients out of the 2,700 that were on that arm actually had to stop the treatment because of diarrhea. So that was felt to be a toxicity that was manageable, and to lower the risk of recurrence by 25 to 28%, with having this mild diarrhea, it was felt to be tolerable. And then certainly you can adjust the dose of the medication to help that to be more tolerable. One thing I do want to mention here is when you look at the actual patient population, the majority of patients in this study were those who did have a lot of positive lymph nodes. So that was the biggest patient population. And only, 40% of patients had 1 to 3. It looks like there's a couple stragglers in each arm who did not have any positive nodes, which technically made them not eligible for the study. And you can see the other details. So I always think that's important too, is when you're looking at results of a study, is asking yourself, how do I fit into this? Are these tumors like mine? So in conclusion, abemaciclib or Verzenio, when combined with anti-estrogen therapy, either tamoxifen or aromatase inhibitors, significantly improved the IDFS, the invasive disease-free survival, and also improved the chance of the cancer spreading somewhere else. There was the greatest reduction in distant metastases to the liver and the bone, and the safety was things that we already know about abemaciclib, and the diarrhea, which is our big side effect we worry about, was manageable. And then interestingly, a lot of times with the hormone therapy, we see side effects of arthralgias and hot flashes, and this was something that actually appeared to be a little bit less for whatever reason when the abemaciclib was given. So this is the first drug to show a significant improvement in invasive disease-free survival when given with endocrine therapy, specifically in patients who are high risk. Now, at the same time that this abemaciclib study was taking place, we had 2 other studies available. One of these studies was called PALIS, and one of these studies was called Penelope. And these studies were with palbociclib, or Ibrance is the other name for palbociclib. And actually, both of these studies were negative, so they did not meet the primary endpoint. They did not lessen the chance of cancer coming back. So our big question is why? And in part, these studies included lower risk patients, so they weren't just limiting it to multiple lymph nodes, high grade, high Ki-67. So that's maybe a speculation. There are some biochemical differences between abemaciclib and palbociclib in terms of potency for either CDK4 or CDK6. We think that could be an important setting. And also, interestingly, it's not an issue in the metastatic setting. So in the metastatic setting, both of these drugs work really well. So that kind of leaves you scratching your head a little bit if it's more of a clinical trial design issue, a patient population issue. But as it looks right now, I do anticipate that abemaciclib will get approved. And it's something I'm talking to my patients about in clinic as I'm seeing them now, that it may be at your next visit that we have this drug available and we can give it to you. But the IBRANCE or the palbociclib studies, those studies were negative. So the drug works well in metastatic patients, does not appear to have the same benefit in moderate risk early stage patients. So switching gears a little bit, I know that Dr. Brofsky mentioned as well regarding immunotherapy, and immunotherapy is something that we have available for early stage patients as well. So right now, atezolizumab is the only drug that's FDA approved in specifically triple negative disease, that's stage 4. But immunotherapy has been studied in other settings, and I do think this is also something that is likely to become practice changing in the next 6 to 12 months for patients who have early stage triple negative. So everything I'm going to talk about now in the next set of slides is specifically for folks who are triple negative. So you may have seen this slide before, but this talks a little bit about how PD-1 and PD-L1 work. So immunotherapy means different things to different people. Currently, we're using the terminology immunotherapy predominantly to reflect the use of checkpoint inhibitors. So these checkpoint inhibitors are the pathways looking at the interaction between the tumor cell and the T cell. And unfortunately, the tumor cells are pretty smart, and they can figure out ways to specifically avoid the immune system. So a lot of what we're looking at with checkpoint inhibitors is to allow the immune system to recognize the cancer cell as something that shouldn't be there. So it's not a normal breast cell. This cell is a problem and you need to get rid of it. And right now, it appears, at least with the data we have currently, that immunotherapy, specifically checkpoint inhibitors, work best when they are combined with chemo. And the reason why we think that is that chemotherapy disrupts the tumor cell architecture. It enhances antigen shedding. So as those tumor cells are dying off, they're releasing their DNA into the bloodstream, and it kind of gives the immune system something to look at. And then also induces rapid disease control. So the immunotherapy that we have currently is more of a passive type mechanism. So it's basically saying getting rid of a blockade and doing a stimulation, as opposed to chemotherapy, which is actually disrupting the DNA and killing off the tumor cells in that way. So the two major drugs that we've studied in breast cancer are pembrolizumab and atezolizumab, and you've heard about both of those drugs in the metastatic setting. Again, we're going to focus on it in early stage. There are a couple key differences, so they're not really interchangeable drugs. I do think that's something that's important to understand. And pembrolizumab is a PD-1 antibody, and it binds to the PD-1 receptor on T cells. The atezolizumab is a PD-L1 antibody and binds to PD-L1 on tumor cells and tumor infiltrating lymphocytes. They actually use different assays for each. In order to be considered a candidate for pembrolizumab, the 22C3 assay is used. For atezolizumab, the SP142 assay is used. That's something that the pathologists take care of. So your oncologist would order those assays, and the pathologist would check your tumor to see if you were positive for either of these. And currently, pembrolizumab has been studied in both advanced or stage 4 disease as well as early stage disease. Atezolizumab has an approval as first-line metastatic disease if the tumor is PD-L1 positive, but also has been studied in the neoadjuvant setting. So neoadjuvant are those studies that we're doing prior to breast surgery. So an important thing, and this is something that probably many of the folks on the call are aware of, particularly if you have triple negative disease, is that many times we will do chemotherapy first. And the reason why we do chemotherapy first is that a large proportion of triple negative cancers will completely go away with chemotherapy. And those are these patients right here, and that's called PCR, pathologic complete response. But then there's also some triple negative patients, and these are the ones here on this red curve, who don't have a pathologic complete response. And what you can see here on this side of the curve, it's called event-free survival probability. So the chance of the cancer, the chance that somebody doesn't have the cancer, come back and is alive and without cancer recurrence, that is higher, so closer to 1 if you have a pathologic complete response, but it's lower or farther than 1 if you don't. So typically what we think is that if you have a pathologic complete response, your chance of the cancer coming back could be as high as 50%. So our main goal in triple negative disease is how can we improve the pathologic complete response? So with that, a lot of our studies are aimed at improving that pathologic complete response because that in turn helps the cancer not to come back and helps people to live longer. So when we talk about pathologic complete response, it's people who get chemo treatment, then get surgery, then get followed over time. And this is a very common strategy that we use for patients who have triple negative disease. So the first study I will talk about is the pembrolizumab or the Keytruda study. This study was called Keynote 522, and it looked at standard chemo, so carboplatin, paclitaxel, adriamycin, Cytoxan, so our standard backbone. And there was a randomization 2-to-1 to either pembrolizumab plus the standard chemo or placebo plus the standard chemo. And again, as I mentioned before, the placebo was either the pembrolizumab or placebo, but everybody in the study got the standard chemo. So everybody got chemo, but then a proportion of patients also got the pembrolizumab. So in this study, you had to be triple negative. Your tumor had to be at least 2 centimeters or bigger. It could be smaller than 2 centimeters, but if that were the case, you had to have lymph nodes involved, and there had to be tissue for correlative analysis. And many times when someone's on a research study, we will do something called a research biopsy, which is to test the tumor to see how well certain treatments may or may not work. And I know at the time, and it's not to minimize the discomfort associated with extra biopsies, but these biopsies are really important, as you'll see in the upcoming slides. So all the patients in this study got all of this treatment, then they had their surgery, and then after surgery, they were either given pembrolizumab every 3 weeks or placebo every 3 weeks. So again, after surgery, there's no standard treatment, or at the time that this study was done, there was no standard treatment. So in order to get placebo here, this was the standard of care. So moving on, in this particular study, 83% of patients were PD-L1 positive, and this is using the assay for Keytruda. Everyone in this study got carboplatin. About half the patients got it every week. The other half of patients got it every 3 weeks. And this was a pretty big study, 700 patients plus in the pembro arm, 390 patients in the chemo alone arm. So what was found, and this was really exciting, is that in the patients who just got chemo, their pathologic complete response rate was 50%. And this is about what we quote in patients who are getting AC, Taxol, carboplatin. But overall, if the pembro was added to the chemo, the pathologic complete response rate shot up to 64.8%. So that means that 2/3 of the patients had no cancer at all left at the time of surgery, and we think these are the patients who are cured long-term. So this was very exciting news. Now, when you looked at it, so remember how people had to have a research biopsy. So what they looked at in the research biopsy was the PD-L1 testing, and what they found is that if you were PD-L1 positive, your chance of pathologic complete response was even higher if you got the pembro added to chemo, 68.9%. But it was also pretty high, 54.9% with chemotherapy alone. So very strong numbers of pathologic complete response. But what was really interesting and quite honestly unexpected was what if you were PD-L1 negative? And what was found is that if you were PD-L1 negative, you actually still did better with the pembrolizumab added. So those patients, their pathologic complete response rate was 45.3% compared to just 30% with chemotherapy alone. So this is really exciting data that we are trying to understand more, but what it tells us is that there's probably a benefit to immunotherapy even if you don't have this marker for PD-L1 positivity, and that is completely different than what we saw in the metastatic setting. So there are changes that occur to tumors over time. So really exciting data. The FDA is currently evaluating this to say, is this enough benefit for us to approve this drug? And if we approve it, do we approve it just in PD-L1 positive patients, or do we approve it in everybody? Now, again, it's great to have a pathologic complete response, but what we really want is people to live longer with their breast cancer. We don't want people to have breast cancer that comes back and they pass away from. So what they looked at in the most recent update of this is if you got the pembrolizumab plus the chemo, there was a 7% chance at 18 months of having the cancer come back and to pass away from cancer, to die from breast cancer. But that was 11% if you got placebo. So there was also an improvement in survival. And that's, again, our gold standard. We don't want cancer to come back, but we ultimately want people to live longer and not to pass away from, not to die from breast cancer. So moving onward, there was an additional study that was done, and this was done with atezolizumab. So this is the Tecentriq drug that we have approved for stage 4 disease. And in this study, this was just presented a couple months ago at one of our European cancer meetings. And this study looked at patients, and everybody got nab-paclitaxel or Abraxane, which is a drug like Taxol but slightly different, and the adriamycin and the Cytoxan. And this was a 1-to-1 randomization. So half the patients had atezolizumab added to that, and the other half of patients had placebo added, so they just got the standard chemo. And the question is, well, what happened to these patients? Very similar patient population to what we saw with the Keynote study. All these patients then had surgery, and then the half that were getting the atezolizumab continued that for a period of time after surgery versus observation alone in the patients who just got the chemo by itself. And what was found in this study is very similar. The chemo-only response rate's about 40%, and that's actually a pretty standard response rate that we would see without carboplatin. And when the atezolizumab was added, the pathologic complete response rate went up to 57.6%. And again, just bear in mind that this did not have carboplatin added, it just had the taxane drug by itself. And then very similarly to what we saw with Keytruda, is that the patients who were PD-L1 positive had a very high pathologic complete response rate, 68.8%, when the atezolizumab or the immunotherapy was added to chemo, compared to 49% with chemo alone. And then also similarly to what we saw in the Keytruda study, is that if patients received chemotherapy plus the atezolizumab and they were PD-L1 negative, their pathologic complete response rate was 47%. But if they did not receive the atezolizumab, if they just got chemo by itself, their response rate was 34%. So again, another study showing us that there is some benefit to immunotherapy, even if you are PD-L1 negative. So the question is then going to become, well, how much benefit is benefit? So similarly, they had an early look at survival. And again, this is not powered at this time, but similarly also saw an improvement in survival with the addition of the immunotherapy. So again, this is our gold standard. This is what we want, is for people not to die from breast cancer. So conclusions regarding immunotherapy in early triple negative disease. There appears to be a consistent benefit in pathologic complete response and early improvement seen in survival. We do need to follow these patients longer. Ultimately, the FDA is going to decide what they think is most important. And I think there's still an outstanding question of Taxol versus Abraxane and the addition of carboplatin to that. So in the meantime, I encourage those of you who might be in a decision time point, or if somebody asks you, what do you think I should do about joining a clinical trial? We have a clinical trial specifically for early triple negative disease. This is NSABP B49, and this is giving weekly Taxol with the carboplatin, so similar to what was done in the Keynote study, followed by AC. And in this study, there's a randomization to the atezolizumab or the chemo alone. So this is a study we're excited about and enrolling on. And then hopefully within the next maybe 6 months or so, the FDA will tell us if they have an approval for one of these agents. So I do think this will be practice changing as well. And I think we're running short on time. Am I able to talk a little bit more, or do you guys want me to stop and take some questions? I don't know if Denise, are you out there? If you want me to keep going.
Go, Shannon, you can continue.
Okay, great. So I just wanted to briefly talk about HER2 positive disease. So we talked about ER positive, we talked about triple negative. So what about the HER2 positive patients? And the reason why I mentioned this study is this is a study that supports what our current standard of care is. So there's always been a question with HER2 positive disease is, do you have to get adriamycin or do you not have to get adriamycin? And there was a study that was done that looked at adriamycin-based regimens, that's your red devil drug, as we fondly call it, versus the taxane and the carboplatin and the Herceptin and the Perjeta, to see, did people do any better? So this was a study that also looked at this. And when you look at the response rate with the TCHPs, so Taxol, Taxotere, Carboplatin, Herceptin, Perjeta, compared to the same regimen with the anthracycline added, there was no difference. So you didn't get any benefit from the adriamycin if you were HER2 positive. And then similarly, in terms of survival, you can see now there's no difference here. You can see that is not statistically different. So what they found was there was no benefit to getting adriamycin if you were HER2 positive. And this is just another supporting study of that. So what it really supports is our way that we continue to treat patients. Now, what was different, because pathologic complete response is important for HER2 positive disease too, is that patients who had a pathologic complete response had higher likelihood of survival than patients who did not have a pathologic complete response. But this actually looks pretty good too. This is still pretty nice results for somebody who did not have a pathologic complete response but was HER2 positive. So in conclusion, no benefit to anthracycline in early stage HER2 positive disease. This is yet another study that confirms our current standard of care in these patients. And the problem with the anthracycline is that it increases the risk of side effects, specifically cardiac toxicity. So our next steps with HER2 positive disease are to give less chemo, because there are some patients with HER2 positive disease who do very, very well with Herceptin and Perjeta alone, or who do very, very well with TDM1. So this is actually a type of cancer that currently we are looking to give less treatment to. So that is my last slide there. Certainly really encourage folks to consider clinical trial participation. We have a lot of really exciting drugs. Literally everything I showed you is 2020 research. So new and exciting things coming out all the time, and I'm happy to answer any questions.
Shannon, we have a couple, actually, I have a question. So for those that are interested in participating in clinical trials, how best do they do that for anybody that's on this workshop that's kind of new to all of this?
Yeah, so I would just reach out to your oncologist in the clinic. Our nurse practitioners and our physician assistants are aware of all of our clinical trials. We have a research nurse in clinic every single day. So certainly just ask your doctors about participation. There's also a number that you can call, or an email server. It's called Breast Trials, and that's something that you can just email yourself. So if you're interested in something, or if you wonder if we have a specific study here, but your oncologist will have all of this information.
Great, thanks. One of the questions that we did have that came in, it's actually a three-part question. So I'm going to read the entire question because one question may relate to the other, and then we can break it down if we need to.
Okay.
Since it was noted that ductal and lobular cancers are different, how much work is currently being done to look at the response of different cancers to drugs that are being studied? Are there enough people to tease out the impact? Most studies have high participation of people with ductal cancer, since the overwhelming majority of cancers are ductal. And can people with lobular cancer trust all of the data?
So super question, and I agree. I think that lobular cancer is a little bit of a different beast. In many ways, it's just been wastebasketed along with the ductal cancers. There is some thought that patients who have lobular cancer actually respond differently to hormone therapy, and there's a study we have going on right now. So when we talk about neoadjuvant and we talk about triple negative and HER2 positive, we actually have a neoadjuvant study now for patients who have lobular cancer, where they are given either an aromatase inhibitor or fulvestrant, which is one of those injectable drugs we use in stage 4 disease that blocks estrogen. So there we do have some lobular specific studies. In terms of lobular specific data with CDK4/6 inhibitors, I'm sure that as we have more and more data on those patients, that will be looked at. Again, it's getting enough of those patients, but if you think about something like the abemaciclib study, where you have 5,000 patients, 20% of those are going to be lobular, so you'll have some specific data. So we'll see that data come out of these large adjuvant studies.
All right.
Chris, you can switch the camera.
Thank you very much, Dr. Puhala. That was very well done and very informative for us. Thank you.
Sure, absolutely.
So before everyone leaves the meeting, I do have some final business, just some housekeeping items. I hope you all enjoyed the presentations this evening as much as I did. Big thank you to our presenters, our sponsors, and everyone who is attending tonight. I also want to thank our workshop committee. I want to thank Janice Devine and her team and their organization for this workshop today. And we really hope that you can support them and the work that they do. Information on giving is located on the last page of your program. And anyone from our foundation, our Magee-Womens Research Institute and Foundation, are available to speak with you or schedule a time to meet with you at a later date if that works for you. Finally, tomorrow you will receive an online evaluation via email. Please click the link and complete the evaluation in order to receive a $10 Eaton Park gift card. If you are from out of state or international, Eaton Park is a local joint here, so still fill out the evaluation and you can use that gift card the next time you're in Pittsburgh. The cards will be sent out in about 2 weeks, and completing the evaluations are incredibly important for us as we base our topics for events like this, as well as our Livewell education series, on your suggestions. Thank you again to everyone who participated. Thank you again to all of our presenters. We wish you good health and we hope you have a happy holiday season. Good night, everybody.